Welcome to Coffee with Kyle number 20. I'm Kyle Ridgway. Good evening. So obviously, patients who survive critical illness are imparted an unfortunate burden of many physical, psychological, functional, cognitive, social issues. And much of the talk surrounding ICU Rehab has focused, I think, unfortunately, on rehabilitation or physical therapy or mobility generally acutely within the ICU. And we haven't looked broadly at the continuum of rehabilitation or the possible paths of rehabilitation for individual patients or different patient groups. And I think this has been an error in thinking, but also an error of stepping back and seeing the entire journey of a critical illness. And that's not necessarily anyone's fault. I think, obviously, discovering some of the issues that are associated with critical illness, both acutely and chronically, has been relatively new in the literature. In the past 10 to 20 years, really, have we truly kind of peeled away the layers to understand how devastating the impact of surviving a critical illness is. And even if you don't work in acute care with survivors of critical illness, I think if you apply this perspective to whatever population or clinical problem you work with, I think it will be useful. So briefly, there's a lot of talk about ICU early mobility, ICU early rehabilitation, and unfortunately some of the current evidence that has come out that looks at longer term follow-up, which, in ICU studies, follow-up of 6 months, a year, especially in rehab intervention trials, that's considered longer term follow-up, and those have been awesome trials that have taken a lot of work. I treated within one for a while and can attest to how hard those researchers work to retain folks and get the follow-up they need. But, obviously 6 months to a year is not exactly what everyone else would call longer-term follow-up. In any case, if we look at some of these trials, what we see is that even decently well-designed intervention packages that are imparted early within the ICU don't seem to relate to robust changes at 6 months to a year. And I think this tells us a couple of things. You might hear people say the classic, well, physical therapy doesn't work. And I won't get into today how that's an error of assessment of conflating a profession with an intervention. But what I want to talk about is the fact of why would we assume that an intervention imparted early and in an isolated fashion only during the critical care stay would have remarkably robust effects at 6 months or a year. Now, I would argue that there'd probably some effects, and one of the recent trials that had about, I think the N was 300 people at an enrollment. Unfortunately, they powered their study to the outcome of length of stay, but at each time point, 1, 3, and 6 months, there were close to statistically, but actually clinically important differences between the groups and physical functional measures. But in any case, what this does is, even if we're not explicitly assuming this, what we're implicitly assuming by designing trials like this is that some, if not all, of these deficits that we're seeing at 1, 3, 6 months, a year, 5 years, 10 years after ICU discharge are the result of modifiable risk factors that we can intervene upon early. In other words, the problems that patients are having in the long term are the result of either modifiable factors that we can take care of acutely, or they are actually preventable. And I'm fairly convinced at this point, both via the data that I've seen on outcomes and acute interventions and the outcomes following those, as well as just my personal experience and observation working with these patients acutely and in the long-term acute care setting, so of course that's my biased lens, is that regardless of what we do acutely, not all of these deficits are preventable. Regardless of what we do acutely. Are some of them? Absolutely. Are the magnitude of them? I think so. But the totality of them is absolutely not totally preventable by imparting the best care bundles acutely, the A, B, C, D, E, and now F bundle. Awakening, breathing coordination, delirium screening intervention, early exercise, family engagement. I'm not sure if I have that completely correct, but we'll link some resources so people can fact check me. Even with all of those and integration of therapy disciplines and rehab into the ICU, even with early physical therapy mobility, I do not think that all of these deficits and problems are actually preventable. I really don't. And therefore, what we need to look at is, okay, what can we prevent or what can we modify in the acute environment? But then we have to actually look at a continuum. ICU to ward or the floor, to other care settings, to home, to outpatient, to community resources, to outpatient follow-up. And I think, again, going back to engaging and collaborating, stepping back from the line, broadening our perspective, there may be a lot to learn from other areas of research and other patient populations where it's not perfect, but this concept has been scaled and investigated for a little bit longer. And I think some of those populations that critical care and critical care rehabilitation can learn from include neurologic rehabilitation, both brain injury and spinal cord injury, cardiac rehab, pulmonary rehab, and even now, in relation to all of those, the emerging but fairly well-established field of oncology rehab. And a term that I really learned from Nicole Stout, who's just a brilliant oncology researcher and clinician, is the concept of prospective surveillance. In other words, expecting impairments and limitations to come up and therefore to be constantly surveilling for them and intervening early to either prevent them or address them. And so if we look for a second at the neurologic rehabilitation continuum, both for, I think, brain injury and spinal cord injury are a great example. Nobody assumes or would ever postulate that a really early intervention in the neurologic ICU would profoundly change outcomes for years to come. People understand that there's a continuum here that's based on the diagnosis or the actual lesion, where it is, the severity of it, the patient's previous level of function, their progression and rate of change clinically, both medically, physically, functionally, cognitively. And there's a lot of pathways to try to cohese the rehabilitation and the addressing of many different impairments. So to use, again, brain injury and spinal cord injury, for example, after someone is out of the acute hospitalization phase and they're more medically stable, there are actually model centers for spinal cord injury and brain injury rehabilitation. These are centers that are functioning at a remarkably high level and specialize purely and narrowly in the rehabilitation of patients who have either spinal cord injury or brain injury. And I've talked to some of our physical medicine and rehab colleagues, some of our physiatrists, and I've predicted or posed that maybe in the future we will actually have medically complex or critical illness specialty rehabilitation centers because of the necessary knowledge and training and experience that it takes to likely manage these patients over a long period of time. And in these settings, that it's not purely remediation, right? A C4 complete spinal cord injury has a very low likelihood of ever ambulating again. But these patients may stay in an acute rehabilitation facility or a model center for weeks to months at a time for education on how to direct their care and equipment fitting and compensation for their deficits, and setting them up to have not only a potentially successful home discharge, but also improved quality of life, recreational therapy, modified recreation. And I think, I've been blessed that peripherally I've been exposed to Craig Hospital here in Denver, which is one of the model centers for spinal cord injury and brain injury rehabilitation. And to think that maybe we could do this with survivors of critical illness is a profound question to me. But if you look at even cardiac and pulmonary rehab, the concept that you have this either chronic or acute medical event, and we actually need to, in the outpatient setting, focus on activity, exercise, and rehabilitation. And in the cardiac rehabilitation literature, it's been very well established that patients who attend cardiac rehab, not only do they have a morbidity benefit, they actually have a pretty profound mortality benefit, which is really crazy to think about. So when I see all of us who work in critical care, work with survivors of critical illness, discussing ICU follow-up clinics, what's the best way to handle these patients acutely? Why aren't we finding more, excuse me, more robust effects of our acute interventions within the ICU? I think we can look to other disciplines and other patient populations to see, it may be a way more complex than what we're assuming. And so I think the future of managing the deficits after critical care is not a singular pathway, but rather it's the understanding that we need to stratify people based on known clinical variables and baseline variables, but as well as dynamic prognostic indicators of progression and rate of progression into different care pathways and different care, different care settings. And that providers in those settings are actually likely going to be specialized not just in the acute management of critical illness, but in the subacute and long-term management of survivors of critical illness. And I really urge us to consider collaborating with and diving deeper into the models that are used, again, in neurologic rehabilitation, including spinal cord injury, brain injury, and stroke, from time of diagnosis all the way back to community integration and community support programs, cardiac and pulmonary rehabilitation, and oncology prospective surveillance and rehabilitation. And I think if we learn from the mistakes of those folks who have a lot of experience with this and apply those type of models and problem-solving processes to the patients that we're seeing acutely and who survive critical illness, I think we'll be set up for much, much more success. So thank you for listening. It was good to see you. Have a great evening.